can surgery ever cause melanoma tumours to become angry and spread?
The short answer is no. That is, surgery to remove the tumour can't. There was actually, in the early days of sentinel node biopsy, there were some people who thought that doing a sentinel node biopsy might cause the cancer to recur somewhere in between where the melanoma started and where the lymph node was. But there have been multiple studies done that have shown that that's not the case. What can sometimes make melanomas more aggressive is when they're not treated with an excision, but they're treated with some other type of treatment like burning or freezing. And so that's why the guidelines clearly state that if a melanoma is suspected, that it should be completely excised to make the diagnosis. So if you have a mole that you're worried about, or that's changing, or the word melanoma appears, the way that it should be diagnosed is for the whole thing to be cut out.
David, I might add to that. You mentioned about the guidelines being rewritten and how important it is for consumers, patients, those affected, to contribute to those. I think perhaps we've all done not the best job at communicating how people can contribute. But perhaps you could speak to that.
Yeah, so in previous iterations of the guidelines, they've come out as a booklet or as an online PDF. Currently it's being designed as a wiki, so the idea is that they are live and they can be updated regularly, and so it's on the NHMRC website and they're freely accessible, and that's true that they do go through a relatively limited period of time where they're open to public comment. But if you just put NHMRC melanoma guidelines into the Google, then it'll take you to the right page.
And perhaps I can make it easier and communicate that better to people. Take that on.
Good one.
And then a question now for one of our oncologists. Do you think that patients with a long response, do you think they are cured? Is there a cure? Are we cured?
Jonathan, you should take that.
So I don't think we can say that people with long remissions are cured. Many will live normal lives, but as was exemplified by that transplant case that I showed, melanoma can exist in equilibrium with the immune system in hidden places and can come out under certain circumstances. The example I gave showed someone who received a bone marrow transplant. Sometimes people get diseases which need to be treated with large doses of immunosuppressive drugs. An attack of an autoimmune disease, for example, or a second cancer. Lymphoma is a disease that's treated with fairly immunosuppressive chemotherapy. And every now and again, you see cases where someone gets a dose of something which really knocks your immune system flat, and a melanoma which was thought to have long been dealt with can reoccur. So in many patients it may well be that they're cured and that there is no disease left, but we can never be 100% certain. So unfortunately there's always going to be a tiny element of uncertainty there.
So next one that we've got is, what is the recommended regime for PET scans? I think this is a really good question. For PET scans and CT scans, if there is no evidence of disease, how often should you be?
Well, I've got the microphone, so I'll start, but these guys can correct me. So, there's different people have a different view on this. If you look at those survival curves and have a look at the shape of the curve, for more advanced stages of disease, and presumably you're talking about patients who have had, say, advanced metastatic disease and had a good response to treatment. If you look at those survival curves, the first 4 or 5 years are the sort of steep part of the curve where relapses tend to occur, and then they start to flatten out. So my practice is to watch more closely during those initial years, and then to spread the appointments out to less and less frequency after about the 4 to 5 year mark. But it depends a little bit on the individual circumstances of the patient. So if patients have got features of their disease which indicate that they've, that there's a greater level of concern because of some of the biological characteristics of the tumour down the microscope, often we'll watch them a little bit more closely. But I'd be interested in seeing what Grant or David have to say to that.
Yeah, I certainly agree, Jonathan, with that first 4 to 5 years, and in fact the first 2 to 3 is the biggest risk period, for particularly if there's been spread to the lymph glands. It's a controversial area actually, and we have a thing called evidence-based medicine where you try to generate clinical trial evidence for the use of things like scans. And we know for bowel cancer, for example, that doing scans and doing blood tests for recurrence actually improves outcomes. We don't actually know that for melanoma, but put very simply, we do scans in people at risk of relapse, and the reason is that we've got these new treatments now, and we don't want to wait till the disease causes a lot of symptoms before starting those. We want to start when we can pick something up on a scan and start early when any lumps that recur are small. I don't know if David's got any comment. Yeah.
I don't have a lot to add other than that there are generally pretty good risk calculators that we can use, and so here at Peter Mac and in my general practice, the scanning regimen changes depending on the risk of recurrence. And I think the other thing that Grant alluded to there is you need to ask yourself why you're doing the scans. And so particularly for elderly patients, I have a very frank discussion about if you were to have a scan that showed a recurrence, would you want to start treatment? And so at some point, you decide that I don't really want to know, and then you don't do the scan. But for most patients, and certainly for most patients in the audience here, I think that routine surveillance scans are very reasonable and would be done as part of routine practice.
I'm asking them all at the moment, but please, if you do want to ask one, just raise your hand and we've got a mic.
I might just add one more comment on the scans issue. So scans can be bad. When can they be bad? Well, they're bad if they give you a scare that melanoma might have recurred when it hasn't. And so we don't like doing scans when the chances of any positive result being melanoma is very low. So let's say you've had a very thin melanoma, that there's a greater than 97% chance of cure. We definitely do not do scans in that situation because you're far more likely to find something that is not anything to do with melanoma. That can lead to unnecessary biopsies and certainly a lot of stress and worry. So we don't do scans for low risk situations.
Next one is what is our current understanding, or what is yours, not mine, of the human wart virus as a risk factor in developing melanoma?
Grant, Jonathan.
Let the social worker answer.
So viruses and cancer is a very interesting area. So and actually in Jonathan's area of immune treatments for cancer, some of the viral cancers respond very well. But the typical type of virus, the papillomavirus that causes warts, I'm not aware of any evidence that it's linked to melanoma.
But it is associated with other skin cancers, squamous cell carcinoma.
Yes, but not melanoma. Yep.
I have another. We've heard a lot about combination treatments. At the moment, obviously on the PBS, we've got the targeted therapy combination, but in terms of the other immunotherapies, it's only monotherapy. Where do you think the future will be in treating melanoma? Will it be in combinations?
So that's where the trials are taking us. It's pretty clear that there are some patients who don't need combinations. There are some patients out there who get complete remissions with monotherapy.
You have one right there.
Monotherapy Keytruda. Okay, there's others in the room as well.
Yes.
So you don't want to over-treat people with expensive medication and put them at risk of side effects that they don't need. So selecting patients is going to be critically important. So you do need to identify the factors that enable you to say this patient is going to do just fine with monotherapy, drug, whatever. But you similarly need to be able to say, in this situation, I know monotherapy is not going to work. They need more than that. And then the question is, what is it that they need? And it's the clinical trials that are now being done which will help us to answer those questions. So the sorts of trials that are currently underway involve combining, you know, a RAF inhibitor with a MEK inhibitor with a checkpoint inhibitor, or a checkpoint inhibitor with an IDO inhibitor. IDO is an enzyme which interferes with immune function. You know, so these combinations are being tested at the moment, and they'll find a way, you know, they'll find a place into the armamentarium, and soon it won't just be a question of, you know, a RAF inhibitor or an immunotherapy. It'll be, okay, what sort of immunotherapy given the particular characteristics of this patient and their tumour.
How far away do you think the predictive tests are that we can be certain that yes, you should go on that, or no, you know, because they're not there yet, are they?
No, they're not, and it's evolving. It's a rapidly evolving field. It's just extraordinary to look at. If you look at the scientific publications that have come out, say in the last 2 years, so there was some terrific. There was an issue of Nature, which is, you know, one of the foremost scientific journals, which was December 2014. That's not all that long ago, right? It's a year and a half ago. In which some of the first really interesting sort of biomarker studies come out, which were linked with some of the biology that helped us to understand, you know, how the lymphocytes are coming in and what they're doing and so on. So in 18 months, you know, our understanding has increased and the technologies are being rolled out, and these really sophisticated techniques which involve genomics and immunology and a whole lot of stuff that in the past, you know, were just fantasy, are now being evaluated in laboratories in major centres around the world. So it's moving very fast. I think the big challenge is going to be that these labs, which are often research laboratories, aren't doing the sorts of assays that get approved by government as standard reimbursed assays for, you know, a Medicare reimbursement. And so there's going to be this interesting challenge of how these sophisticated, very informative, complex assays get turned into useful tests that can be, you know, that can be ordered, you know, by the surgeon and done by the local path lab. So that's the challenge. And Grant, I think, has probably got some thoughts on that. I'd be interested to know. It's certainly an area that's exercised a lot of people.
Yeah, it's you know, we've got actually a major collaboration here in Melbourne that Jonathan chairs actually, to try to do personalised medicine for immune treatments, because we think this is the holy grail, so you can pick the best test. But there's a lot of possibilities, and I think it's going to take a while before we get there. But it's really important. You know, I was just at a meeting this week actually where we suggested that the new government's Medical Research Future Fund, that's going to be a large amount of money to invest in medical research, that this would be a really fruitful area, trying to predict, you know, which patients are going to respond to which treatments. You've been on the immune checkpoint treatment. Does it prevent you from getting new skin cancers? We would like to hope so, but we don't know, and that's research has to be done. We have to analyse that with because. You know, new skin cancers only come up, fortunately, infrequently, except for a small subset of patients. You have to actually wait a while and get lots of data on that. But it's a really good hypothesis, a really good idea, and we're going to be very interested to see what the results are. Anecdotally, I've had some people with that have had a lot of sun damage to their skin that have done very well on the checkpoint immune drugs, stop them, and I've wondered whether the skin cancers have become more frequent after they stopped it, but that's very anecdotal, and we need to do the proper scientific analysis.
So you want to be able to celebrate that and to be able to offer people hope where it exists, and to be able to, on the other hand, you don't want to be deceptive. You don't want to fool people. You don't want to tell them that you know, that there's hope if the situation isn't hopeful. So finding that balance is very difficult, and I think that it often takes getting to know the patient, understanding them, understanding their families, and being frank, and trying to find that balance between being able to offer hope on the one hand, and then if it's clear that things are not working out, to be able to be frank and to talk about what the options really are, and what the future looks like. And in many situations, you're faced with something which is in the middle, where you just don't know what the outcome's going to be, where things can look pretty desperate and then they turn around. So on the one hand, you want to be able to hold out hope. On the other hand, you don't want to pull the rug from under people. So it is very challenging. I hate to say this, perhaps I shouldn't, but in the old days it was easy, because you knew people were going to die, and you were able to have that conversation with people, and you could have that conversation with a certain amount of confidence about the circumstances in which you were dealing with things. Now there's uncertainty that's introduced, which in many ways I think makes life more complicated. More complicated in a good way, of course, but still more complicated.
They had the palliative care team and the oncologist, and people would see, we're all part of the team. So palliative care was part of, ensuring quality of life. So treatment on one hand, and I think that you guys are all trained for cure. I mean, that's how and we're all of us in this world are trained to problem solve, and the hope thing is a huge thing. But I think that hope can be to the point, and I've spoken to plenty of people who eventually die. I mean, we all eventually die, but in that living until you die process, hope can change from hope for a cure or to hope for, enjoying the day with my 2-year-old or whatever it is. I mean, I'm not trying to dismiss it. I think taking hope from people, when people hear, my doctor said I've got 3 months, so you sell all your stuff, and, I think we can take hope from people. It's a fine balance, as you've all said. But palliative care, it's very true what you said. It's not terminal care. It's about quality of life. It's about living the life you have, the best life you can have. And if you don't want to keep flogging on with a treatment that's making you completely unwell to the point where you suffer and then you die, well, then, you've got to be given that choice.